We'll talk about telemedicine. The title of the chapter is Telemedicine and the Emergency Physician or Emergency Clinician. And we'll walk briefly through these questions and through the literature just to give you a sense of where this is and give you an update. So I like the beginning of this chapter because it talks about what was done in the sense of telemedicine without technology in the past. So smoke signals were used in villages in Africa to alert other villages of disease outbreaks. In the Middle Ages, they used bonfires to let people know, hey, bubonic plague is coming. So if you're seeing a bonfire, it has a different meaning today than it used to. And in 1906, Eindhoven successfully transmitted an ECG over telephone lines. So this has been going on for quite some time, and more recently with NASA in the 1960s, they were monitoring astronauts. Not a new concept, but the technology has exploded, and the need is much different. To bring this down to the individual patient level, as opposed to broad public health communication or a very specific program like NASA, this is down to the individual person in a community receiving care differently than they did before, particularly for low acuity cases and low acuity visits where patients may not feel they need to go to the emergency department or can't go to the emergency department or don't or can't go to primary care. This technology really provides another solution for them. Although, I will tell you, as we discussed the other day, low acuity visits have gone a lot of places, and they have reduced in the past few years in emergency medicine. They're going to retail clinics, urgent care centers. Some are going to freestanding emergency departments, and you would think that a lot are going to telemedicine. Not yet. But when the barriers are brought down in telemedicine, to avoid issues with data transmission and protected health information, billing and coding, licensure. Right now, licensure is required in the state where the care is provided. So if you are in New York and you're caring for a patient in Tennessee, you have to have a Tennessee license. So licensure is an issue that has limited the ability to use this technology, but I don't see those limitations being significant, lasting more than another 12 to 24 months. The federal government, payers, and other stakeholders want to use this technology, and these limitations are not allowing it, and this is an avenue to cost reduction, so it is absolutely going to happen. All right, so the first question, what is the role of telemedicine in pre-hospital care? Well, we think it's been evident in recent years what we can do with it, even if it's simply for transmission of an ECG, to look at dysrhythmia, for STEMIs, to make destination choices, maybe for stroke. We talked about that not being necessarily as viable as we would like it to be, but also for trauma. It has been very helpful also. And so we know that there is benefit there. Cleveland Clinic looked at this regarding strokes. And so they looked at having a mobile stroke unit. Thrombolytics were administered to 16 mobile stroke unit patients and 12 controls. Time to lytics, 55.5 versus 94 minutes. From the alarm, it's not symptom onset, the EMS alarm when that was sounded. So I think that you will see more of this, and this will be further expanded for stroke. Number 2 is kind of interesting by Schwindling, and they had a mobile stroke unit, but they saw somebody who was an elderly lady. Her age was 74. She fell and hit her head, and they're making a use case for a mobile stroke unit based on this case report, and I'm struggling to get to where they got to. So she hit her head, they did a CT and found no intracranial hemorrhage or other sign of significant injury, so they knew that they didn't need to take her to a trauma center, she could go somewhere else. That's why we're driving around town with a CT scanner in the back of an ambulance. I'm not so sure this makes the value proposition for me, but that's abstract number 2. Abstract number 3, implementing a mobile stroke unit program in the United States. Why, how, when, and how much? This is from the University of Texas. They looked at the data that's out there, was largely German studies, and spoke to their own experience. The German study said there's really no increase in complications from pre-hospital administration of TPA. Earlier notification may reduce delays for endovascular treatment. And one study showed a twofold more likely discharge home for those treated by the mobile stroke unit within 60 minutes of symptom onset. So you would have a larger percentage of people, because they were treated so much earlier, were well enough to go home. The Houston program, Initial startup cost $600,000. So other programs have reported lower numbers, but this is not an inconsequential expense, and this is pretty significant. And I think we really have to look at how many patients we could impact and what we're going to do with them. So that 74-year-old patient, was it worth the expense to send her to a different hospital? She probably would have had the CT scan performed at either hospital, and both hospitals would have identified she did not have an intracranial injury, and she would have gone home. So which is more expense? The mobile stroke unit for that purpose, or just sending her maybe to a trauma center when she could have gone to a community hospital? I think the answer is pretty clear. The mobile stroke unit value proposition can't be made on using it for cases other than stroke, and can we really say that that's really going to help us based on the level of technology they can provide to get patients to the right institution? I think it's yet to be seen how they'll develop that technology for that purpose in particular. Abstract number 4 from Vanderbilt, retrospective cohort. Now they looked at 1,427 adults with spinal injuries, and this is a little bit of a stretch also regarding telemedicine. And these were transfers they received between the years of 2009 and 2013, so 5 years. Transfer was considered inappropriate for isolated, intact, stable cases, and when an orthopedist or neurosurgeon was already on staff at the transferring facility. So if you were transferring someone and you had the resources at your facility, particularly if it was isolated and stable, he said you didn't need to send them to us. 29%. Isolated spine, non-critical, neurologically intact patients were transferred. 14% by helicopter at a cost of just under $20,000. Ultimately discharged 78% of these people. 42% of the transfers were inappropriate. Average transport cost was $1,863. Average ED cost was just under $12,000 all in. A lot of cost for inappropriate transfers. Okay, so let's bring it back to the discussion at hand and the context of telemedicine. So they're saying that teleradiography may be the solution. How about just a good, healthy conversation on a good old telephone? Do you need to transfer this person? Are they stable? Do you already have a neurosurgeon? You've already done studies. Hopefully we won't repeat the studies, but that's oftentimes what happens to get higher quality studies, make sure nothing has changed. I think the answer here isn't telemedicine, it's better communication. And abstract number 5, it's from the Brussels Stroke Registry, 2,282 stroke patients to implement their program. And what they did was they wanted to establish the time gain needed for in-ambulance telemedicine, the cost-utility model. When you look at cost-utility modeling, you know that there's going to be some, let's say, creativity with this methodological design. They're modeling it. If it looked like this is what we project would happen. So they said the implementation cost would be about $160,000. Based on the Houston program, this is an underestimate. They said, which is fascinating, this program was cost-effective at a 6-minute gain and dominant, meaning irrefutable, at a 12-minute gain. So if we save the patient 12 minutes of time, they're saying it's worth this expense. I think that's overly generous. We can burn up 6 or 12 minutes in a variety of ways that are out of our control very quickly that would eat up this hypothetical benefit from a time savings. So I don't really see it. They said over 82% of all probabilistic simulations that they came up with, in-ambulance telemedicine remains under the cost-effectiveness threshold of $47,747 for 82% of these patients. And that's overall stroke care per patient. I think they are trying to make the argument, but I don't think they successfully did. So abstract number 5, I think, falls short of making the cost-effective argument for mobile stroke units. All right, the next question, is telemedicine helpful to the emergency physician or emergency clinician? Abstracts 6 through 8, we'll run through these quickly. They're different concepts. So the goal in abstract number 6 was describe the prevalence of telemedicine in New England. 195 emergency departments. It was a survey. The response rate was pretty good, 87%. And what were people doing with telemedicine? Just shy of 50%, 49% were using telemedicine somehow, more likely in a rural environment. So 18% of users were in rural environments, but only 7% of non-users were in a rural environment. So you were more likely to use this in a rural environment, and in particular on multivariate analysis, they found that a rural community, Odds ratio to use this was 4.39, and less likely in EDs with 24/7 neurology availability, an odds ratio of 0.21. And also, if you had an annual volume of less than 20,000, the odds ratio was 0.24. So really, really small, low-volume places, interestingly enough, weren't using it. Maybe it was because of cost, maybe it was a volume of patients, but they just weren't using it, where sometimes you might think those type of facilities might have a benefit in using it. The use cases that were identified were neurostroke 68% of the time, pediatrics 11% of the time, and psychiatry 11% of the time, and trauma 10% of the time. There were also a few other applications, but they were just a small percentage of those who used it. Number 7, prospective convenience sample. This is interesting. What they did was they had overflow in their emergency department from triage. We're going to be sending people back to the waiting room anyway, so let's put one of our faculty emergency physicians in a room somewhere, and let's have them do telemedicine on these people, and let's have it verified later by one of the on-site physicians. They could complete the care if it was low acuity, or they could then facilitate a warm handoff and transition of care to the emergency care team in the ED on site. So it was pretty interesting, and I think there was some value in doing this. So, and by the way, if I didn't mention it, all visits were then confirmed by the on-site emergency physician prior to discharge. Small study, 130 patients, mean ESI level, so the emergency severity index level was 3.9. So we know that 1 and 2 are high acuity visits, 3 is kind of intermediate acuity with intermediate resource utilization, 4s and 5s are low resource utilization, translating also to low acuity. So these were almost all level 4s, low acuity visits, median throughput time, which was very helpful, 150 minutes versus 287 minutes, comparing similarly situated patients. So basically, when they triaged patients to the ED instead of to this telemedicine physician, the same types of patients with same ESI categories were looked at. They were in the ED a lot longer. So this does save time. And by the way, mean patient satisfaction scores were 4.91. Patients seemed to like it. There was 1 potential misdiagnosis and no adverse events. This happens. I know systems that are doing this, and it does work pretty well. It's a matter of whether you have the ability to put the program in place and you can afford the technology that is required. Abstract number 8, a prospective cohort. This was more of a community study. Primary care geriatrics practices serving 20 senior living communities. 6 were intervention sites, 16 were controls. And what happened with the participants? So the control participants had 0.195 emergency department visits per person year. The intervention group had 0.138, an odds ratio of 0.71. So if they created this network and said you can contact these people by telemedicine, did they need additional resources? No, it saved resource utilization, and it made it easier for the patients. So I think it does help. Matter of fact, it reduced ED utilization by 34% annually. So that's important. And if they don't need to be there and there's a better way to deliver care, then we should explore those options and opportunities. The next question, can telemedicine reliably assess pediatric patients? It's abstract number 9, and I think we can. I was surprised because they selected some complex presentations, and they found that there was benefit if they followed an algorithm. So 132 febrile children, 2 to 36 months. And I was surprised. A 2-month-old who's febrile trying to assess whether they're sick or not by telemedicine, I was skeptical and still am to a certain degree, but they found value in using the Yale Observation Scale. On 145 between 2 and 18 months with respiratory symptoms, they used the respiratory observation checklist. Telemedicine versus bedside evaluation, they found with the febrile kids, strong agreement by Pearson correlation coefficient. And for the respiratory distress kids, excellent agreement with a kappa value of 0.81. It actually works. So what we're saying is when they compared it to on-site evaluation versus telemedicine, there was very good correlation that the clinicians came up with the same assessment. Not perfect, but it is pretty good. And these are relatively high-risk complaints. So I thought this was pretty impressive and promising that we may be able to sort out some complex diseases, not just low acuity visits by telemedicine. Next question, can telepsychiatry be used to assess patients with psychiatric problems in the emergency department? And yes, they absolutely can. And I think that's going to be a great solution for us going forward, knowing that the vast majority of mental health patients who are boarding in emergency departments in the United States are boarding not waiting for a bed, but waiting for their mental health evaluation. I think the number is very close to just north of 80% of those ultimately get discharged. So if we can get the mental health evaluation to them quicker, we can decompress our EDs. Yes, do we need more resources for outpatient management and referral? We do. But what we need is more expeditious mental health evaluation so we can get people who are amenable to outpatient treatment to the outpatient environment. And so I think this will really help. And Abstract 10 speaks to a couple programs, one in Texas and one in North Carolina that were implemented. And North Carolina, I will just comment about quickly. Statewide telepsychiatry initiative, and it saved the state $7 million while providing better care and quality and access. So when we will get to a nationally scalable program for telepsychiatry, I couldn't begin to tell you, but it needs to happen yesterday. And there's evidence like this to show that it not only will improve outcomes, it should reduce ED overcrowding and crowding and boarding of these patients, and it's going to provide better access and better outcomes for our patients. All right, the next question. Could teledermatology be useful to the emergency provider? This is just a series of comments with a few citations. Yes. 98% in one study said we would love to have it, and a couple studies that are cited here but not abstracted say that, when you look at diagnosis by images versus on-site evaluation, the correlation is really, really good, but it's not perfect. Some things are lost in the evaluation that are not just visual. So it's not perfect, but I think it makes a lot of sense, and we need this level of interaction because sending images of a patient by personal cell phone or non-encrypted, non-HIPAA compliant means of transmitting protected health information is not a good solution, but we know what happens today. So we need to be careful with that. The next question, how can telemedicine impact ED visits? Well, I mentioned it before as well, and when we bring down some of the barriers, this will be another avenue for low acuity visits for patients, and they may have the opportunity to not have to go anywhere. But we've not seen the full impact of telemedicine. It's a very small fraction of where the visits have gone to date. As a matter of fact, the use of some of these services can reduce ED visits by around 10% and office visits by 30 to 50% by some estimates. Yes? Wow. So you're having a dramatic impact that you're seeing in the post-acute space. And I'm not surprised. And we need to leverage technology to provide better and more efficient and cost-effective care. And it sounds like where you're working, you're absolutely doing that. The next question, is telemedicine helpful to the intensivist? Well, yes and no. It's Abstract 11. You would think it would be great. If you can't have an intensivist in every critical care unit, can you do this by telemedicine? You're largely, once the patient is admitted and you know the diagnosis, you're largely managing by the numbers, aren't you? I don't mean to simplify or oversimplify what intensivists do. They do great work. But once, at a certain point of care, particularly overnight, you're not changing lines, you're not doing other things, you are managing what is happening with those patients. And some of this is amenable to telemedicine. It really can work. So I'll just share some of the data in Abstract 11. So they looked at 132 case hospitals, which was more than 145,000 patients, 389 control hospitals, more than 411,000 patients, and they said the use of ICU telemedicine was associated with a lower risk of 90-day mortality with an odds ratio of 0.96, just a tiny bit. Remember, 1 is even. So they did declare, because this was statistically significant, that this made a difference. But what's interesting, when you look at the rest of the data, the study, it calls into question really if that impact existed or not. So after adoption of telemedicine in 132 case hospitals, mortality rates remained the same in 81% of the cases. It decreased significantly in 12%. Okay, good. So 12% we really impacted, and it got worse in 7%. So did we not provide the right level of care in 7%? Did we not need this in 81%? And how do we impact this smaller percentage? So If we're going to say that this isn't broadly applicable to all patients in the ICU, then which patients? And are we going to create infrastructure with technology and human resources? We're going to employ intensivists in a command center. Which patients are we going to impact, and how many can we impact? And it calls into question the real value of these programs. So maybe those questions will be answered, and maybe there will be true benefit. But broadly applying this to all patients in intensive care units clearly doesn't seem to be of value based on this data. All right, and there's a series of questions we'll run through quickly. Is healthcare about to enter a new phase? Absolutely. Amazon, Apple, Google, Microsoft, and others are entering the healthcare space to try and do it better. We're using technology with smartphones to do things for patients that we haven't done before. What are some uses of telemedicine in low-income countries? Fascinating data. As of 2017, 2/3 of the world's population are connected by mobile devices. It's amazing. 82% of the population in Africa have mobile connections, and it's increasing at a rate of 4% annually. So people have the devices. We can, again, leverage the technology to do population health management, to do all kinds of different things with them. And so lots of things have been proposed and could work. Smartphones have been used for laboratory analysis, visual acuity, cataract screening, diagnosis of malaria. We know that we have done many things with them, such as even blood glucose monitoring. So we will see more of this. The next question, can telemedicine be useful in the patient with syncope, dizziness, or TIA? We know that we can put portable monitors on people, and we can connect them with cellular service to make sure that 911 is called, the patient is advised, and we can get good data on patients. There are patients, as noted in this question, that actually are identified to have dysrhythmia that were asymptomatic. There were patients who were really symptomatic and had nothing. And so if we can get real-time data on this, telemedicine can really help us. And the next and final question, what are some of the other uses of telemedicine? Smoking cessation works. Also, there was some discussion about text 4, the number 4, baby. So during prenatal care, some advice can be given in a regular mechanism once you sign up for this, and even after the baby's born, you can convert your account to get good information on the care of your newborn. And so many different ways to apply telemedicine that we haven't fully explored at this point, and some ways we have explored that may not be as cost-effective. We will find the balance in the near future, I'm certain. It will help improve access, hopefully quality outcomes, and certainly will reduce the expense of healthcare delivery. Well, thanks for staying and listening to this discussion, and I really enjoyed spending my time with you this week. Take care, everyone.